Going live in 3, 2, 1.
Hello everybody. Welcome today to our Cancer Primary Care webinar series, the first in the series, and we're covering cervical screening and colposcopy. If I could introduce the team to you. So here today we've got Catherine Nestor, Fanta Bertang, our main speaker, Adam Rosenthal, who many of you will know, and I'll do a little bit of tidying up at the end. We are going to run for about an hour, and you'll be able to access these slides after the event. So just a very brief introduction to the Cancer Alliance. We're one of 21 cancer alliances, and we're focused, we primarily exist to improve early diagnosis and treatment. We develop pathways for treatment, supporting research and development, and we champion innovation of that R&D outcome in practice. We cover the London boroughs of Barnet, of Camden, Enfield, Harringay and Islington, so therefore our STP. And of course, our partners are our patients, our GP practices, our hospital trusts, the commissioners, councils and charities. We're an NHS organisation, and we exist to transform and improve healthcare strategy and organisational systems for cancer for the benefit of our population. So thanks very much for organising, for signing in for today. In terms of some general housekeeping, as I said, it's the first in the series. We've got a webinar on head and neck cancer happening next Thursday at the same time, and we've got a registration link in the chat box. Please join us for that. We're recording this webinar and it's being hosted on the NCL Cancer Alliance's YouTube channel, so you can access that later. Please post your questions in the chat box as we're going along, and we'll collate them and answer them throughout the session. We've included a feedback survey after the webinar, and the link's going to be posted at the end of the chat in the chat box. If you can complete that, that would be great. What this feedback will really help us design our future meetings going forward. And we'd like to give our apologies in relation to the initial advert, which described Sapna Shah, Dr. Sapna Shah, who would have been joining Dr. Rosenthal, but unfortunately she's had a family emergency, so she's not with us today. So Adam is kindly stepping in and covering all of the clinical work, and Fanta is going to talk a little bit about the initial changes and challenges that COVID has brought to the services. Okay, so if I can introduce Fanta. Fanta's our prevention and screening programme lead at the Cancer Alliance, and she's going to talk to us a little bit about the COVID challenge. Thanks very much. Thank you, Fanta.
I think I'm unmuted now. Good afternoon, everybody. So I'll do just a very quick update on where we're at with the screening program. As everybody would be aware, the program had to be paused at the height of the pandemic due to most resources being diverted to responding to COVID. But as of June, the invitations were resumed, and we had to increase the invitation rates in order to be able to catch up the program. So this has now reverted back to the normal rates at which invitations are usually sent out, including reminder letters as well. It reverted back to normal levels in October, and we have seen a significant increase in the number of samples that are being collected by primary care, which has been really encouraging. Prior to the program restarting, NHS England and PHE had completed some predictions of what the collection rates are going to look like, and this was based on pre-COVID data, but we have actually surpassed that prediction. In terms of colposcopy services, again, they have all been working very hard and have cleared their backlogs that were generated as a result of the pause. But as you would expect, with the increased number of samples being collected since the program restarted, the number of women who are being referred has started to increase again. Again, HSL as well had to pause some of their activities and make some changes to how their transport services were running, but this has now returned back to normal levels. and they are almost at their pre-COVID activity levels as well. So coverage is one element that we haven't got data just yet on how the figures are looking like since the program restarted, but I've just indicated where we're at pre-COVID, and as you would see, across all our 5 boroughs, we have not been meeting the 80% coverage target, which is the national target. However, for some boroughs, they have been doing a fantastic job, and they're not very far off in terms of achieving that. Our focus over the next few months and going beyond that is very much going to be around looking at initiatives that can be delivered in order to improve coverage, particularly within the younger population. So on this slide, I've just highlighted what I've indicated in terms of colposcopy. So from the middle of September, we saw a sharp rise in referral rates. And this is basically going back to about pre-COVID levels. But the services do have capacity to see women and continue to manage. And the chart at the bottom, which is looking at the samples that have been collected since June. Again, a huge increase from July, and this is down to primary care just responding really swiftly and increasing their capacity. So you'll see from the table below the activity levels comparing 2019-20 to this year. And so far, we have been very much ahead of what has been predicted. There's still some work to be done in order to be able to close that gap of just over 4,500 women who are yet to be seen, who were invited in the last few months. So just to touch very briefly as well on the initiatives that are running, almost all practices in NCL are taking part in the Pan-London cervical screening text reminders, and this is run by NHS England. Again, they restarted a few months ago, and in terms of success rate of how text messages are being delivered, it's variable across the SDP. However, we're hitting between 70 and 80% largely. And we have some other pieces of work as well that are running. In Haringey, the GP Federation has been contracted to work with 19 practices. These are mainly practices who have lower coverage in comparison to other practices within the borough, just to support them to get more women in to be seen either at their practice or in the hub. And we'll be replicating this model as well in Enfield. So those were the main points that I just wanted to highlight about the program. But I think all in all, the program is doing quite well in terms of recovery. Thank you. Claire, I think you're on mute.
Sorry. Thanks, Fanta. Thank you very much. Catherine, are there any other questions that we might like to address now? I can't see any. You haven't had any email through? No.
No, not on the screening services. Okay. No. So we can move on to Adam.
All right, thank you. So that's it's been a real challenge for us, but primary care has been fantastic, as Fanta said, in their response to the COVID challenge and getting us back on our feet again. So thanks very much to all of you. If I could ask Adam Rosenthal, consultant gynecologist and lead colposcopist in the trust. And Adam, you're kindly going to give us your talk and a little bit of an extra bit about what we were otherwise going to miss. So thank you very much for coming today. And I think you're going to talk a bit and show us some interesting slides, and you're happy to answer questions as we go through the presentation. Thank you very much. Thank you.
Thanks for the introduction, Claire. Thanks everyone for coming. I hope you can see my slide. It should be coming up in a second. If perhaps someone could let me know if they are able to see the slides.
You can see the slides, I think. Yeah.
Okay, great. So this is me. And can you see the next slide? Because if this one works, I know they're all going to work. Can you see the slide showing two documents on it?
Yes, with gov.
Brilliant, thank you, great. So we're okay, we're up and running. So in terms of actually what guidance is out there at a national level, these are really the two documents that I think are relevant, and I'm not personally aware of any more recent publications. The first one on the left is really concerning just symptomatic.
I've lost your slide now. That's it here? Yeah.
Okay. The first one is concerning young women with abnormal vaginal bleeding, and that was really in response to two issues. One was the fact that the screening programme age had been raised, and there was a lot of public controversy about that. And the other issue was that there were a few cases of cervical cancer being missed nationally in this age group. And the concern was that people weren't properly investigating younger women with abnormal bleeding. And then the other document is actually a website now. It used to be hard copy, but now we only get it electronically. And it's the NHS publication, CSP publication 20. Rather than that long URL which I've got there, if you just Google NHS CSP 20, then you will get this this website up. And this is really the Bible by which colposcopy services have to run themselves. But there are sections which are highly relevant to primary care, which I will go over briefly. So going back to that first document, the one about younger women, this is the somewhat complicated flowchart suggesting as to how they should be managed. I'm not going to take you through it box by box because that would take the whole hour, but it's actually, I think, worth printing this out and sticking it on your wall somewhere, perhaps for your practice nurse who maybe does most of your smears, because it is, I think, relevant to how you manage women when they're below the age of having a smear. And I think the cardinal issue here is it's always better to have a look than not have a look. And it's always better to do the simple things first, like a screen for infection with a nucleic acid amplification test for chlamydia, and making sure that the woman hasn't had a recent change in her contraceptive choices, because that might obviously be influence bleeding. But I think it's always safer to have a look than to not have a look. If nothing else, you can reassure women if you're happy their cervix looks normal. So I think it's worth going back over that at some point when you've got the time. So this is moving on now to the national colposcopy guidance, but this is highly relevant to what you're seeing in your practice. So this is guidance for referring women, nothing to do with their abnormal smears. This is because of symptoms. So the symptoms, of course, that we're interested in are predominantly postcoital bleeding, but in fact any kind of irregular intermenstrual bleeding might be relevant, because tumours don't obey hormones. They just bleed randomly, particularly on contact, hence why intercourse can trigger bleeding if you've got a tumour. Also, persistent discharge can occasionally be a sign of a cancer. And these women have symptoms, so they're not suitable for screening. That's the key point. We've always got to keep in the back of our minds in medicine the difference between screening and differential diagnosis. Someone without symptoms is someone you can do screening on. Someone with symptoms, you have to do differential diagnosis, and they're not suitable for screening, so you shouldn't take a smear. And there are a couple of reasons for that in this particular context. One is that taking a smear might end up delaying your diagnosis. The lab recently had to clear a big backlog, and smears were taking over a month to be reported. So if you'd been waiting for a smear report, you might have delayed a diagnosis and delayed a referral. The other thing is taking the smear can shear off the surface epithelium and make it harder for a colposcopist to assess what's going on. So if you think someone's got a really worrying looking cervix, please don't take a smear. I'm sure most of you don't. We very rarely come across it in colposcopy. We think GPs are very good at adhering to this advice. But the next point I think is crucial. If common causes have been excluded in primary care, so please, unless you've got a barn door cancer sat at the end of your speculum, then please do these simple tests first, because we do want to try and limit the number of urgent referrals. We're always happy to see a cervix for an opinion, but it's seeing them within 2 weeks can be quite tricky, and therefore we really want you to try and prioritise the women according to how likely it is you think they've got cancer. And if you really don't think it's very likely, then please send them as a non-urgent referral. Remember that contact bleeding at the time of a smear is normal for many women, particularly younger women, and it's not in itself an indication for referral to colposcopy in the absence of other symptoms or suspicious appearances. But of course, if you do think there is something dodgy going on, then please do refer, and we should endeavour to see your patients within 2 weeks where possible. Please also remember that age is not an issue here. This applies really to any age, and in the case of postmenopausal women, rather than it being infection, it's more likely to be vaginal atrophy. The cervical and vaginal epithelium, as you know, become much more delicate in the postmenopausal years. And if you haven't got any obviously suspicious features and there are no risk factors, for example, a previous history of CIN, then I wouldn't be too concerned about a little bit of bleeding. You go through the normal postmenopausal bleeding workup for them, but unless you can see an abnormal cervix, don't send them straight to colposcopy. Put them through your normal protocol, which I assume would involve getting a transvaginal scan. So turning back to the risk factors, because remember, whenever you're assessing a patient for likelihood of having cancer, in the back of your mind you should have what makes it more likely the patient I'm seeing has cancer as a cause of their symptoms or the appearance of their cervix. So it's a previous history of anogenital HPV infection. We are actually beginning to see an increase in anal cancer, and anal cancer is due to high-risk HPV types as well. Vulval and vaginal cancers are rare, but they do occur. We do see them in primary care. You're not going to see them very often, but just be aware that they are all linked. And if you've got someone that's previously had disease on their cervix, they're more likely to have disease in the vagina, vulva, or anus. If they've ever had a positive high-risk HPV test, then that is highly relevant. Immunosuppression, in particular poorly controlled HIV, but also solid organ transplant patients on high dose of immunosuppressants, they are at significantly increased risk of developing cancer if they have high-risk HPV. Smoking is a risk factor. Always encourage your patients to stop smoking, and having an abnormal smear is actually an ideal opportunity to try and get some traction with them about giving up smoking. If they've never had previous screening and they're coming to you perhaps as an immigrant, particularly from a country where there hasn't been a screening program, we in the 2000s, when we saw patients with Eastern European names coming to our clinics, we got anxious because we knew they were coming possibly with their first ever smear, and that smear being abnormal when they've not had a previous smear done in their own country before they came to the UK means it's much more concerning that they may have a cervical cancer already at the point at which they're getting referred because of an abnormal smear. And of course, nowadays, if a woman has not been vaccinated, that would count as a risk factor for development of cervical or other anogenital HPV-related cancers. So a very brief bit, if I may, of medical school anatomy, and this is just to help you understand the pictures that you're going to see later on. So we talk about the squamocolumnar junction. This is where the skin on the outside of the cervix meets the glandular lining of the endocervical canal, and that junction changes position depending on where you are in your reproductive life. So looking at those two epitheliums, on the left you've got the squamous. So what you can see, I don't know if you can see my cursor, is lots and lots of different layers of squamous epithelium. So there are lots of cells between the surface and the underlying blood vessels, and that means not only is this resilient to bleeding, but also it looks pink rather than red. If you contrast that with the columnar glandular epithelium on the right hand side of the slide, you've got a single layer of cells, and then you're straight onto the blood vessels underneath, and that's why glandular epithelium appears much redder than squamous epithelium, and it also explains why it bleeds more easily, because there's only one cell layer protecting the blood vessels compared with the multiple cell layers that you get on the squamous epithelium. So here is a picture of what I hope you would guess is the glandular epithelium. It's this very kind of sea anemone-like epithelium when it's magnified. It really does look like little fingers of a sea anemone when you look at it up close. So that's columnar or glandular epithelium that secretes cervical mucus. And here you can see in a prepubertal girl, because there's no estrogen around yet, the junction would actually be hidden or just within the cervical os. So you probably wouldn't see any glandular epithelium at all. here you've got a process of eversion going on as estrogen comes in, and then the junction is further out. So if you looked at this head on, you would see that typical target appearance with the delicate red lining in the middle and the tougher pink lining on the more periphery of the cervix. And the 5 Ps, as I call it, causing eversion. This is a little bit of a con, but it's the mnemonic I used to use at medical school. Parturition, so if you've just been born, this is what your cervix would look like. We actually know this from post-mortem specimens on stillbirth. It's not a very nice subject, but it's important to understand the anatomy. So it's good that at least at some point someone did that study. Puberty is the main issue. That's when it really begins to happen. Being on the combined oral contraceptive pill will do the same or even accentuate it. Pregnancy will also accentuate it. And postmenopausal, but only if you're on HRT. So actually, if you're postmenopausal and not on HRT, as I'll show you in a moment, this does not apply. And what is it that links all of these? It is estrogen. So if you're a woman in a high estrogen state, then you're likely to have a visible squamocolumnar junction on the ectocervix. You should be able to see those differences. So here in a post-adolescent cervix, you've got what we call the transformation zone, which is where you've got this area of glandular epithelium that's gradually toughening up in order to become squamous and be less likely to bleed, to be less delicate. And that's gradually happening here. So now you've got the new squamocolumnar junction is beginning to get hidden up in the canal in a postmenopausal woman, because for years and years her glandular epithelium has been exposed into the vagina and has been toughening up with the process of metaplasia, and then as the estrogen goes away, the cervix inverts rather than everts, and this junction can get hidden up inside the cervical canal. So here you've got someone who's undergoing metaplasia. So this is the squamocolumnar junction. So you can see there's squamous epithelium below my cursor, but everything in the middle is glandular epithelium. And where you've got the white arrows, you can see here that this is an area that's metaplased. It's gone from glandular to squamous. And the reason you know it's metaplased is there's some gland openings. These tiny dots are gland openings, and here you've actually got a little island of glandular tissue that hasn't yet metaplased. So this is incomplete metaplasia, and by the time the woman is postmenopausal, this entire area will be covered in squamous epithelium. So here you've just got the labels showing you what's going on there. I hope that's clear. So now on to the bit more fun stuff. 2-week wait or not 2-week wait, that is the question. And here it looks like Yorick has actually decided to behead the prince. So 2-week wait or not 2-week wait. I'm sorry we can't do this directly interactively. Normally I'd ask you to shout out in the audience, but these are examples of normal cervical ectopies, or ectropion as people also call it. This is one that's got incomplete metaplasia, so it's not completely frondy. This one is very frondy and in fact has contact bleeding, and the squamocolumnar junction is going around here, and this is normal. It looks a bit scary if you've never seen it before, but actually it's got relatively even appearance. I wouldn't be desperately upset if someone sent me a patient like this, but preferably not as a 2-week wait. If they were symptomatic and had a bit of postcoital spotting but were under the age of cervical smears, or if they'd had a normal cervical smear previously, I wouldn't be too concerned about this, but I fully accept if you're not that experienced at looking at cervixes, then one like this might look a little bit concerning if you've never seen it before. This one here, however, I would be a little bit disappointed if someone sent that up as a 2-week wait, because I don't really think there's anything suspicious about that. So here's one that looks or two that look a little bit more interesting. You've got some prominent blood vessels. Now, you know that prominent blood vessels can be a sign of cancer, but I want you to note the absence of ulceration, the fact that this is a very even, smooth looking surface on both of them. You've got normal looking squamocolumnar junction here with a bit of glandular epithelium. Here you've got very little visible glandular epithelium. This is really all squamous. This is, in fact, as I'm sure most of you, if not all of you, will have recognised, Nabothean follicles or cysts. These occur as a result of the metaplasia, because if the squamous epithelium covers over the glandular crypt, then what can happen is that crypt can continue secreting mucus and it can't get out anywhere because it's covered by that thick layer of squamous epithelium, and it builds up into something that can actually look quite dramatic. Because it stretches the blood vessels and obstructs them, they can get quite big and angry looking, but really apart from the big blood vessels there is nothing else suspicious about this. And big blood vessels on their own, in the absence of ulceration and irregular surfaces, are not something to worry about. So I would hope people wouldn't send this kind of appearance up as a 2-week wait. Now these are very dramatic pictures, in particular these two here. These look really quite extraordinary with lots and lots of blood vessels, and I would see 1 or 2 cases like this a year. So they're not very common, but actually these are actually all just more of the same. These are all just Nabothean follicles. There are loads and loads of them on these ones, very big ones on this one, and one obstructing the os here with the threads of a coil you can see there as well. But you could argue, well, that's a lump, it's a tumour. Yes, it's a tumour, strictly speaking, but it's got a smooth surface. Yes, it's got a couple of bigger blood vessels, but it's not irregular. It's got a nice contour. There's no ulceration. There's nothing that looks delicate. So that really shouldn't make you think of cancer. These look really dramatic, and I think it would be not unreasonable to send these up for a second opinion because you see them very unusually. And anything that looks really weird, I think you have the perfect right to send up and say, listen, I really don't know what this is. Do you mind just giving us a second opinion? And I think that's absolutely fine. So here is a cervix that's got a bit of bleeding on it. In fact, this bleeding looks like it might be below the surface because it's not kind of dribbling down. A pale whitish appearance, maybe looks slightly irregular, but nothing that screams cancer to me at least. And that is actually a typical postmenopausal cervix. It's very thin and kind of whitish in appearance, even with the naked eye. It's got little petechial hemorrhages underneath the surface, and that's because the thickness of that epithelium, that stratified squamous epithelium, is thinner in the absence of estrogen. So you can see blood vessels sometimes directly, more easily, such as here. There's no Nabothean follicle, but you can just see the blood vessels that I'm pointing at there. And because it's so delicate, even the act of opening the speculum, even if you use lubrication properly, is still enough just to traumatize the epithelium so that it bleeds just below the surface. So it's effectively bruising itself. And if you see something like this in a postmenopausal woman who's got a bit of bleeding, comes to you saying, I've seen blood, doctor, then, well, you still need to get the transvaginal scan. But if the scan is negative, you're going to be happy to give her estrogen because that's hopefully going to resolve her symptoms. And I would argue you can do all of that with your scan and then giving her the estrogens in primary care. I don't really see why you need to send a patient like this up for an opinion if you're happy that that cervix doesn't look like cancer. Here is another one. This is really the same situation, but with more dramatic petechial hemorrhages underneath the surface, and that's as a result of you putting the speculum in, almost certainly. But again, there's no kind of vicious, irregular, nasty looking surface anywhere there. There's no ulceration, so that shouldn't be of a particular concern to you. So again, that's the postmenopausal cervix. So here we've got some quite interesting ones. I would think you would hopefully recognize what these are. These are both endocervical polyps, but they're slightly different. This one has got a smooth surface and is obviously congested. It's a bright purple color, and that's because the vessels will have been, the venous outflow vessels have been constricted within the canal. So it's swollen up a bit like a prolapsed hemorrhoid. This one is still covered in a largely glandular epithelium. You can see it's got a frondy covering, very similar to the frondiness you've got here, the sea anemone-like appearance of the glandular epithelium. So this hasn't yet undergone metaplasia to look like the squamous epithelium that you can see here more peripherally. But these are both exactly the same thing, and 99.9% of the time they're benign, and risk factors for them not being benign would be very large size, older age, or obvious ulceration or bleeding from the surface. Now, this is really dramatic, and I would expect a patient like this to be sent up as a 2-week wait. But what you're looking at here is actually a fibroid polyp, and I probably see 1 or 2 of these a year. And this is where there's been a polyp growing within usually the womb cavity or the cervical canal cavity, and the uterus recognizes this is foreign and tries to extrude it, and it extrudes it through the os. It gets gradually more elongated on a stalk and eventually comes out of the cervix. Occasionally they will auto-amputate because they're cutting off their blood supply, and a woman might even come to you with something like this wrapped up in tissue paper and say, "Doctor, I've just passed this through my vagina, what on earth is going on?" And we would obviously ask that to be sent off for histology. Often they're necrotic, and they can't get histopath on them, but feel free to send someone like this up via a 2-week wait pathway, just because they're so unusual and it's such a dramatic thing. And very occasionally, once in a blue moon, it'll turn out to be a sarcoma. So I think if you've got a really large, funny looking thing like this, even if it looks pretty benign as this one does, I would still send it up for an opinion. So I would very much hope you all recognise this, because I hope this is more kind of bread and butter primary care stuff. It would certainly be bread and butter in an STI clinic, and I'm sure you'd all recognise that as Candida, and you would be able to wipe that off using a swab. It might cause a little bit of bleeding underneath the surface when you wipe it off if it's a particularly a dramatic case where it's causing a lot of inflammation. The one on the left here, there's a lot of erythema, so this is good going candidiasis with a cervicitis going on with it. So this again is something you might well see in primary care. You would certainly see it in an STI clinic, and I'm giving you a clue there. These are all condyloma or warts due to low risk HPV types 6 and 11, and these are more sessile or flat warts, and this is a much more papilliferous lesion, not unlike the glandular lining, but it's a bit whiter and a bit more prominent than the glandular lining is. So that is another wart. Here we've got what is known as strawberry cervixes. These are all different. This is a very pathognomonic picture. You don't see these very often, at least not in my clinic. Again, you might do if you worked in an STI clinic, but you could certainly see this in primary care in a patient complaining of a discharge, and that is our friend Trichomonas. And believe it or not, someone's made a cuddly toy of he or she. So there you go, that's Trichomonas strawberry cervix, that's not cancer. So getting on to cancer now, so this is the meat of it, if you like. According to the International Federation, these are the 4 sort of features to look for with cancer. Now, I appreciate you are not doing colposcopy in primary care. You do not have access to all of the lovely equipment that I do. Your lights are probably not as bright as a colposcope. You probably don't have a colposcopy type couch where a woman can have her legs adducted, hopefully comfortably, to get her cervix a bit more easy to access. And you also haven't got all of the great variety of different sizes and shapes of speculums that we've got probably. So I don't expect you to be able to see the bottom 3 things easily or at all. You certainly wouldn't see these at all. But I would expect you with a decent light to be able to see irregular surface contour, erosion and ulceration. And I mean erosion here in terms of a true ulcer. I'm not talking about erosion as a misnomer for a normal healthy cervical ectopy in a young woman or anyone else with a lot of estrogen around. Atypical vessels, as I've discussed, you can see them with the naked eye, but if they're happening in the absence of an irregular surface contour and ulceration, then you shouldn't get too uptight about them, because that might just be due to being postmenopausal and you being able to see the vessels easily because of a thin surface epithelium, or it might be because they've got an Abothian follicle which is stretching the vessels over the surface. So this is cancer, 3 different cases of cancer, and I really hope you can see the difference between these and the ectopies that I was showing you earlier. dramatically ulcerated, very irregular surface with a lot of spontaneous contact bleeding. I hope you would agree this actually is yellow and sloughy and is necrotic, and if you biopsied that, it would probably come back as necrotic tissue, and they'd be unable to make a diagnosis on it because it would be so necrotic. What you would need to be doing in colposcopy would be taking biopsies from the healthier bit on the edge, where you're more likely to get cancer than here where you've got necrosis. And then here on the next picture, you've got a slightly more subtle case. Now you could perhaps mistake this for an ectopy, but I would argue the clues here are the large amount of blood pooling in the speculum. That's not a normal amount of bleeding unless someone's on the middle of their period. And here you've got an area which is looking more ulcerated and prominently delicate and frondy than the other bit of glandular epithelium over here. So this looks different to this, and that's why that is suspicious. And here you've got one again occupying most of the cervix. You've actually got what looks like a normal squamocolumnar junction here, but you've got this very irregular surface contour, areas which are kind of whitish even without, I can tell you this is without the application of acetic acid. This is just different paleness compared to other areas. There's some yellow bits, some kind of spontaneously bleeding bits, and it really looks like a mountain range up close here. This is clearly cancer, not a cervical ectopy or erosion. Now here's an interesting one. Okay, so this looks very frondy and has also got quite a lot of contact bleeding. Actually, it's a very delicate and large condyloma, but personally I would expect to see this referred as a 2-week wait, because I think it is very large, very prominent and very delicate, and I think you don't see these very often, and it would be very reasonable to send this up as a suspected cancer. Now this is actually, I'll give you a clue here, this is actually in the vagina, but you might notice this, you might see, put a speculum in and see this area of sort of different epithelium. That's healthy epithelium, that looks unhealthy. This is healthy epithelium, that looks unhealthy. They're prominent blood vessels and there is some ulceration and contact bleeding. And this is actually vaginal intraepithelial neoplasia, or VAIN3. So that is carcinoma in situ. That's about to become cancer if it isn't already cancer in some places. And if you saw something like that, I would definitely want to see that referred up as a 2-week wait for a possible vaginal cancer. Vaginal cancer is very, very rare. There are probably between 500 and 800 cases a year in the UK, and the majority happen in women that have previously had CIN or a hysterectomy for CIN in particular. But it's very rare. But if you ever did see an ulcer, nasty looking epithelium in the vagina, send that up. We often see some benign cysts sent up. It's not uncommon to get little retention cysts in the vagina or embryological remnants, but again, those are smooth. They're just like Nabatean follicles. They're smooth and round and haven't got ulceration, and they're almost always nothing to worry about. So I would be less worried about that appearance compared to this sort of appearance, where you've got something that clearly looks very different to the surrounding epithelium. Finally, I think, this is, if you like, the little quiz. I'm sorry that we can't ask you directly, but if you look at these different pictures, A, B, C and D, the ones I would want you to refer up would be, drum roll please, B and C. And as it happens, B is condyloma and C is cancer, but that condyloma in B is very extensive looking. It's got a lot of surface bleeding, and I would definitely want to biopsy that to rule out cancer. A is, of course, our friend the Nabatean follicle, and D is just a normal cervical ectopy, and you can see how that contrasts with C, which is this irregular, ulcerated, bleeding, necrotic looking cancer. So 2-week wait or not 2-week wait, that was the question. If in doubt, refer you must, as a wise alien once told us. So Christmas is coming, and believe it or not, you can give your friends and relatives, if they've got a slightly sick sense of humour, a bunch of soft toys. And of course, my favourite is HPV, who is the character on the top left. But you can see you've got herpes, gonorrhea, syphilis and chlamydia that you can give your friends and relatives as well there. And I will leave you with a slide which is advertising an issue which I think Claire might want to briefly speak to. Thank you very much. I'm very happy to take questions.
Thanks very much, Adam, and thanks for the recommendation about the stocking filler. That's great. First time I've seen that. Really, really excellent talk. Thank you very much. I'm sure we've got some really interesting questions that we'll cover in a minute. So I've had two come through which are really on point, so I'll go through those in a second. Just quickly to say to people as this slide is up, is that we have been working at the CCG across all our boroughs with public health about trying to improve the take-up rates for cancer screening with people with learning difficulties and address the wider issues around cancer for our residents with learning difficulties. So here you'll see on the screen now an advert for a launch event on the 3rd of December. Now the event runs for quite some time, as you'll see. You may well not have time to attend, but there might be someone in the practice, perhaps your practice nurse, who'd like to attend, to have a look at a video which has been, it addresses this issue, particularly designed and filmed for our learning disability community. And of course, if you'd like to attend the event, then you would be very, very welcome. The registration is available via a click entry on that last slide. Okay, so thanks very much for that. Let's go to our questions. I've got a really interesting first question, which is, why do women who have solid organ transplants not have annual smears like women do with HIV, if they are classed in the same category in terms of cervical cancer risk?
That's a really good question. Shall I just try? Shall I lose my screen share? I'm not quite sure how to do that, just so people can see me rather than looking at the screen all the time. So I think particularly in the era of very effective antiretroviral therapies, I think we've actually come to a point now where the risk of cancer in well-controlled HIV is nothing like as high as it used to be. Remember, cervical cancer is an AIDS-defining illness. But these days, a well-controlled HIV patient is really not very likely to develop a cervical cancer. Whereas I do a multi-zonal clinic at Homerton, where I see patients who've got neoplasia from the cervix to the anal canal and everywhere in between. And some of our worst patients are those with solid organ transplants on a cocktail of really powerful drugs. Now, we've been to Public Health England about this a couple of times, and the answer comes back so far that the evidence is that that they are not at a very high absolute risk of getting cancer, and it doesn't seem to be higher than HIV, and so for the moment it is reasonable to not give annual smears. I would say that the one thing that's changed, which makes this a safer way of looking at things, is in people with is because of the launch of the primary HPV screening, and the reason for that is that the negative predictive value of a smear which is negative for high risk HPV is very, very powerful. So if we've been unable to detect high risk HPV in anyone, be they an organ transplant recipient, an HIV patient, or just Mrs. Average, their chance of developing cervical cancer in the next year is really very low. And for that reason, I think it's safer to not do smears annually on patients with organ transplants. If they've got a positive smear that's positive for HPV, but negative on cytology, and remember, such patients would not automatically get referred to colposcopy. They would, however, automatically come back for a repeat smear, because hopefully you remember, if you're positive HPV, negative cytology, you have annual smears as long as you remain HPV positive. And if you have 3 annual smears in a row, which are positive for HPV, but negative on cytology, at that point you get referred to colposcopy, because the assumption is the patient has remained positive for HPV for 3 years. It's possible the smear has missed some dyskaryosis, and therefore the safest thing to do is to get them colposcoped. But actually, the data that came through from the primary HPV screening pilot sites, and you remember that was all piloted before it was introduced, as all major changes to screening programs are. That data said that the chance of finding high-grade disease, so CIN2, CIN3 or cancer, in someone who had been HPV positive for 3 years with normal cytology was actually very low indeed. So I think you can be reassured if you're an organ transplant patient on a lot of strong immunosuppressants, but your HPV test is negative on your smear, you don't need to have another smear a year later. If, however, you were positive, then you definitely need to come back a year later for your next smear.
Okay, thank you. So a question in a way following from that was, is it standard practice now for all test of cure to be done in general practice? That's a
really good question, and something that's highly contentious amongst colposcopists. So
ask just before you start the answer, I don't know whether you can try and stop sharing your screen so that we can see you.
Let me just see.
Yeah, that's fine, Alison. I think it's only your face that's on the screen. I think it's fine.
I can't see myself, but as long as you can see me, I guess that's okay. Anyway.
Yeah. So sorry. Thanks. Back to that question. Test of cure.
According to the national guidance, which I gave you that link for, colposcopy clinics are meant to discharge patients to primary care after they've been treated. And I'm told that outside of London, this is very much the norm. We in London are pretty reluctant to do this, and I don't think it's arrogance on our part. I think we've got some very sensible reasons. The first reason is actually we have no easy way of keeping tabs on what's happened to our patients. And you may not be aware, but one of our targets is we are meant to have 90% of our patients who have been treated having a negative test of cure to show we're actually good at doing our treatments, which is actually a very tough target to reach. The last time we audited this in UCLH, we actually had a cure rate of 92%, so I'm very glad about that. But even that is, getting that information is tricky because patients will defer, they will DNA, they will get pregnant, and really finding out what happened to them, even if they're still coming back to your clinic for a test of cure, can be difficult. So that's even with them coming to our clinics for a test of cure, we can't always get the data to show that what we've done is working. My fear, and this is shared by many of my colleagues around London, is that if we send the patients back to primary care, they may feel falsely reassured. They may think, oh, the hospital doesn't really want to see me anymore, I must be fine, forget about it. And then they might be a bit lax about coming to see you. Also, it's just another opportunity for a lapse in communication where, there may be some issue that means that you, as their primary care team, aren't aware that they're meant to be having this done for whatever reason. And another point, which is really key, is that all the data tells us that people that have previously been treated, it remains a risk factor for recurrent disease and cervical cancer out to 20 years. So unless you've had a negative high-risk HPV test following your treatment, you should be considered to be at high risk of developing recurrent CIN and even cervical cancer right out to 20 years or beyond. So I think this is a very high risk cohort, and I don't think that the national guidance takes into account issues like the London population being very itinerant, moving between practices so that you may not be aware they're due their test of cure. The national programme may not be aware of the patient's current contact details and may not be sending reminders to the right address. There are so many reasons why that system can fall down, and yet this is the one group who you really want to make sure are followed up properly to make sure that they've been cured. So I personally, and many of my colleagues within London, are wanting to carry on holding on to these women, and we're only going to see reasonable numbers of such women for the next 2 to 3 years, because with the vaccinated cohort coming through, we know that the number of women with abnormal smears coming through to colposcopy is going to fall off a cliff edge in the next 3 years. The number of women in your practices at risk of cervical cancer is going to rapidly diminish because so many less of them are going to get infected with high-risk HPV. So I think it's a short-term problem, but I can sleep better at night knowing that the women that our department treats are coming back where possible for their test of cure. And it's only about 150 odd women a year, I think, at the last count. I'm willing for us to have 150 appointments. They're nearly always nurse-led, and usually they're actually smear rather than smear plus colposcopy, because the protocol we use is if you've got clear margins or only a positive ectocervical margin, which is the bit you could see at colposcopy, then you don't have to re-colposcope them necessarily. You can just get a nurse-led smear clinic in your colposcopy department to do them. So I don't see it as a big impact on resources within the colposcopy department, but I think it's a way of us keeping track of the women and making sure they're safe. And that, after all, is our whole raison d'etre. And if we can't do that, then it's kind of like, what's the point in screening women in the first place? So I really am very reluctant to send women back to primary care.
Well,
for their
very
test of
clear.
cure.
I mean, you've given a very clear and robust answer to that, and I think for us in primary care, we'd be very comfortable with that at the moment. Absolutely. Going on to another question, which is not quite pure clinical, but around process and medical legal responsibility, which I'd be great to have your opinion on. So someone's asked, can we update smear reports from women who've had the test in another country? Where do we stand medico-legally?
That's a really good question. I would say that the easy answer would be where you've got a result from a private lab, that's absolutely valid, assuming it's an accredited laboratory, which I can't imagine any private practitioner wouldn't be using. We would absolutely love it to be updated because it often saves us hassle. And in fact, just a plea actually, while I'm on that subject, if you have got the last smear report, if you could send that in with your referral, that often saves a bit of time and hassle on our part. But in theory,
the smear was taken. You mean wherever the smear was taken when you send that in?
Yeah, I mean, I think we would be, well, actually the HSL lab, I mean, I don't want to dump them with more work, but actually they would be best placed to tell you whether a smear done in another country was valid or not. I think it can be very variable. I've never been asked this question around the cervix, but I have been asked it around my other special interest, which is women at risk of inherited gynae cancers because of gene mutations.
Yeah.
And we are working very closely with Great Ormond Street, who are our regional cancer genetics centre, and they're very used to getting gene test reports from abroad. And they're pretty good at knowing which labs are kosher, so to speak, and which are not. And they will happily repeat tests if they are concerned that the test that the woman comes to them or to us with from another country has not been done in a valid lab. Right. Many of the genetic testing labs are now mega labs in the United States, for example, with extremely good quality control. And the NHS is very happy to take those tests as being valid and not repeat the sample. So I think the same would go for cervical smears. Right. My suggestion would be you send the result to CSL, Cervical Screening London, and say, are you happy to accept this as from a valid laboratory? Right. And if so, then you may not be able to necessarily get the national programme to update its records, but you could at least let us know, and we could take that into account if we're dealing with the referral.
Yeah, Okay, that's really helpful. Thank you. So we've just got 4 minutes left, and these questions are again really pertinent. So I'm going to give them to you both to you, and you might wind them in one into the other. So the first question is there a timeline to test for HPV alone without the need for a smear test? And the next question was, with the UScreen self-sample program starting, what will the changes be for you?
So I think what we would say is at the moment self-sampling is not approved by the National Screening Programme, so and it shouldn't be done.
NCL, sorry for me interrupting, is the trial, so that may trigger that question. Yeah. So what? Yeah, no, absolutely, and I'm delighted that some of your audience have already heard about this. It's incredibly important, and it is probably going to be the way to reach the hard to reach, or at least some of the hard to reach women, because as you saw from Fanta's slide at the beginning, coverage in London is not anything like as good as it should be. But at the moment, unless they're on the trial, you shouldn't be recommending patients do it. We do know some women have obtained samples from the private sector, or from, I think Boots even were offering samples, and it's tricky because it's not been validated nationally, and there's some work going on to try and validate things separate to UScreen. From my own point of view, I've agreed to the UCLH department seeing women who do test positive on UScreen, but from your own clinical practice, I would certainly encourage participation in the trial, because it's really going to help move things forward nationally. But you shouldn't be encouraging women to do standalone HPV screening separately. If you've got women, I think this is an important clinical point, if you've got women who you can't get a cervical smear from because either they've got vaginal stenosis, or they've got previous trauma, maybe some history of abuse, that means they find it too traumatic, then what I've started doing, rather than bringing in women for GA, and I probably do 2 or 3 GA cervical smears a year, and I do think that's a valid use of GA time in certain circumstances. What I've started doing is being a bit more pragmatic and taking a smear sample from the top of the vagina using a cyto brush, which is less traumatizing than using the standard LBC sampling brush, which is much larger. But that's on my head. You know, I'm taking the responsibility for if a cancer gets missed because of it. But I think that's kinder to the women. I give them the choice. If you send me a patient saying I can't get a smear because she's been traumatized in the past, I will say to her, if you want, I can give you a GA, but if you want, I can just pass a really small brush through your vagina without putting a speculum in, and if you're negative for HPV, we can be very reassured by that. If you're positive for HPV, then I think we should do a GA and do proper colposcopy while you're asleep, and that's the pragmatic approach I've been using. No, that's really helpful and very clear. Thanks very much. I think we've come to the end of our timing, and it's been a really informative session. Thanks both very much to Adam and to Fanta. We'll be shortly posting this on YouTube, so you'll be able to either review what you've heard and seen, or encourage colleagues to see that. I think I'm going to bring the event to an end now. I just wanted to take the opportunity to remind people that we've got our next webinar scheduled for this coming Thursday, the 26th of November, at the same time at 12:30, running for an hour, which is going to be covering head and neck cancer. But in the meantime, we'll be working on getting this up on YouTube, as I've said, on our Alliance channel. And thank you again very much to both Adam and to Fanta. Thank you.
Thanks.
Thank you.